Good morning, good afternoon, or good evening, depending on from where you join with us today. I'm Professor Pradeepa Bandarnayaka, the current president of the Alumni Association of University of Peradeniya. Today is a special day to the Alumni Association of University of Peradeniya. We are about to kick off the AAUP Global Forum 2021. We have identified a current topic of interest for this kickoff. I'm happy to announce that two proud alumni of University of Peradeniya will deliver the session today. On behalf of the Alumni Association of University of Peradeniya, I welcome Professor Malik Peiris, our key speaker today, and the moderator and the discussant, Dr. Champa Ratnatunga. I also welcome the office bearers, the EXCO members, and everyone who joined with us today. We will learn and discuss about COVID-19 vaccines. Without taking much time, let me introduce our moderator, Dr. Champa Ratnatunga. Dr. Champa N. Ratnatunga is a senior lecturer in microbiology and immunology at the Department of Microbiology, Faculty of Medicine, University of Peradeniya. She is an alumnus of Peradeniya Medical School 2021-2022 batch. She received her PhD in immunology from James Cook University, Australia in 2019. Currently, she is working on post-vaccine and post-infection anti-COVID-19 antibodies in different population groups in Sri Lanka. With that little introduction, let me hand over the session to Dr. Champa Ratnatunga. Over to you, Champa. Thank you. Thank you.
Thank you, Professor Pradeepa, for that introduction. Hello, everyone. It is my privilege to be here. And I would like to first thank the Alumni Association for inviting me and also congratulate them on choosing this topic at this moment. It is of current value considering the global situation and also the local situation. We've got massive vaccine rollouts happening all over the world. We've got a massive push on vaccination happening in Sri Lanka as well. And with that massive push, we've got a lot of people wondering, should they get the vaccination, which vaccine is best, and that response we saw in the questions that we were being asked. So this is a time when people have a lot of questions, and we've got a wonderfully eminent speaker with us to clear your doubts for you. So the format today will be that our speaker, Professor Peiris, will have a presentation for about 30 minutes. And then after that, we will have a Q&A session. Sir will address many of your questions that you have written in and during his presentation, and those that we were not addressed, we will address during the Q&A session. Now, of course, you can ask questions during the presentation as well. You have two options. You can go with the Q&A box at the bottom, or you can write it in the chat function as well. We would prefer it if you wrote your questions in the chat function. I repeat, we would prefer it if you wrote your questions in the chat function, and we will address as many of them as possible in the Q&A session at the end. Now, with that, I will get on to my very pleasant task of introducing our speaker. He needs no introduction in this or any other forum, but here goes. So Professor Malik Peiris is the Professor of Virology at the School of Public Health at the University of Hong Kong. He is a clinical and public health virologist with a particular interest in emerging virus diseases at the animal-human interface, including influenza, coronaviruses, and others. He graduated from the University of Peradeniya, then the University of Ceylon, in 1972, and went on to do his DPhil at the University of Oxford in 1980. He was a lecturer and then a senior lecturer in the Department of Microbiology at the Faculty of Medicine, University of Peradeniya, from 1974 to 1988, during which time he established the Virology laboratory, which is still functioning today. He is remembered as a wonderful teacher by his then students. After spending some years in the UK as a clinical virologist, he then settled in Hong Kong in 1995 at the University of Hong Kong, where he remains today. His research has provided understanding on the emergence and spread of the 2009 pandemic of H1N1 virus and on the avian influenza viruses H5N1, H9N2, and H7N9. In 2003, he played a key role in the discovery of that a novel coronavirus was the cause of SARS, severe acute respiratory syndrome, its diagnosis and control. Currently, he is researching the recently emerged MERS virus and, of course, SARS-CoV-2. He co-directs the WHO SARS-CoV-2 reference laboratory and the H5 reference laboratory at the Hong Kong University and serves on many standing committees and ad hoc advisory committees to the WHO and the FAO. He was elected a Fellow of the Royal Society of London in 2006 for his groundbreaking work on the SARS virus and elected a Foreign Associate of the US National Academy of Sciences in 2017. He was awarded the prestigious Canada Gardner Global Health Award this year for his work on SARS and avian influenza. Reading even a fraction of his achievements would take more time than we have today, and so I will stop there. However, I must say that despite his overwhelmingly busy schedule, being one of the top researchers in the world, Professor Peiris has never forgotten his roots. He never refuses an invitation from us at the department or from anyone at Peradeniya and goes out of his way to be available for commitments in Sri Lanka whenever he can. And whenever he's in the country, he always drops in to check on us and make sure we're doing okay. Sir, thank you very much for accepting our invitation. We are proud and honored to have you with us today. Over to you, sir.
Thank you very much, Champa, for that kind introduction. Can you hear me okay?
Yes, sir.
Yes, sir.
Yeah, okay. So it's a pleasure to be with all of you as alumni of the University of Peradeniya, where both Champa and I learned and graduated. So as she said, what I will do is to, many of you have sent many questions, and my talk of about 30 minutes will try to address many of those. But then after that, we will have a Q&A session in which we will go through some of the other questions that are left over, and both Champa and I will have a discussion and address some of these questions that you have. So the topic today is COVID-19 vaccines, truth versus myth. And I'm afraid there's a lot of myth as well, which can be very harmful. Right, so let's talk about vaccines in general. Now, as you know, the life expectancy in Sri Lanka now is about 78 years or 80 years or thereabouts. And this particular chart shows you the life expectancy in the United States going back through the last century, the 20th century, from the beginning to about 1960. So it's notable to note that at the beginning of last century, the life expectancy in the USA was only about 46, 47 years. And that dramatically increased. And that is true all over the world. Now, the main reason for that improvement in life expectancy is not control of heart disease or treating strokes or whatever it is primarily the control of infectious disease. And one very important component of that was vaccine. So you can see, for example, again, this is data from the United States, and measles activity in the United States, and this is in thousands, mind you, of cases. And measles was quite a significant disease, although it's a fever rash, but a number of children got complications and some of them died. And you can see from the time of the introduction of the vaccine, measles essentially disappeared as a major problem, as it has in Sri Lanka as well. But unfortunately, in the 1970s or 80s, there was a person called Andrew Wakefield who put forward a theory, and he wrote a paper that measles vaccine, or the MMR vaccine, the measles mumps rubella vaccine, is associated with a childhood condition called autism. And that led to a disruption in the vaccination program in many countries, in the West in particular. And because of that, now you see there are people who are not taking the vaccine, although I must emphasize, within a few years, Dr. Wakefield's arguments and his claims and his paper was all shown to be fraudulent, not just wrong, but deliberately fraudulent. And he was struck off the medical register. But the problem is, once one of these, some of these false ideas get into people's heads, then the later, reports that this is wrong does not register. And up to now, there is vaccine hesitancy against the MMR, and that is leading to quite major outbreaks in many countries in Europe, in the United States, etc. And it is important to realize that globally, 3 children die every minute. So by the time we finish this discussion, there would be hundreds of children who would have died globally from vaccine preventable diseases. In other words, if vaccines were delivered, the vaccines that are available now, I'm not talking about COVID vaccines, but a number of the other vaccines such as measles, such as polio, such as rubella, etc., would save so many lives. Now, luckily, Sri Lanka is in a very good position in that regard. We have a very good vaccination program, especially for children. Right. So how does this whole thing work? How, when the body, the human body is exposed to an infection, we do have a number of defense mechanisms that are available to try to combat these infecting viruses or bacteria or parasites. There is if you like, an immediate response from what is called the innate immune system. This is non-specific. So whatever type of virus that comes in or bacterium, these things like the phagocytes, macrophages, neutrophils will go to the site and try to eat and kill these bacteria or viruses. But then there's also a specific immune response, which is basically antibodies and what is called T-cell immunity. And what is most important is that it's not only specific to that invading organism, but you have memory to it. So for example, when somebody gets infected with a virus, for example, you will, after a week or 2 weeks, you will begin to make antibodies to that particular virus. So it's specific to that particular virus. And that antibody and also T-cell response is important in controlling that infection. And essentially, it is a race between the virus and the immune response. So if the immune response kicks in fast enough and controls the virus, basically you get well. And most of the time, that is what happens, fortunately. But if the immune response is slow to take off, the virus gets a head start. And then that is where we have all the problems and ultimately maybe severe disease and death. Now, what we talk about immune memory is that when you are faced with one of these infections, you make this antibody and T-cell response, and after some time that may wane away, but you still will have something so that if you meet that same infection again, you can mount a much faster response. So you can see this gap of about 10 days or so before the first time you meet that infection, but the second time, very, very quickly, you make a faster and a larger response. So this is the memory that is there from the first outbreak. Now, of course, when we want to protect ourselves from infection, one way, of course, is to get infected and then you're protected. But obviously, if it's a serious disease like COVID, if you try to do that, you'll have millions of people who are severely ill and dead. So you would like to achieve this protection, you like to get to this state without having to naturally get infected. And that is where vaccination comes in, because you are essentially giving the body and the immune system, exposing the immune system to some of the proteins of the virus that will trigger this part. The first dose, you have the first part of this antibody response. And then when you get the second dose, you have a much faster, a much higher, and a much more prolonged immune response. So that is why for many of these vaccines, like COVID vaccines, you need 2 doses. Right. So what about the viral vaccines that we know of before we talk about COVID? One way to do this, and the most conventional, the oldest way to develop a vaccine, is to grow the virus up in large volumes, kill it, and then inject it. And so you have all the proteins of the virus in there. This is injected, the immune system gets exposed to it, and it'll make antibodies and T cells, right? And examples of that are the killed polio vaccines, the rabies vaccine. These are examples. Or you can take this virus and make it weaker, attenuate it, so that it is still live, but it has lost the capacity to cause disease. So if you use that and either by ingest or inject those vaccines, they will mimic the natural infection. They will cause a mild infection, but will not cause disease, but you will get the immune response. Or thirdly, you can purify some of the key viral proteins that are important for protection and then inject them, and the body will make an immune response to the virus protein, the key virus protein, usually this surface protein that is out there, which is a protective protein. Now, more recently, of course, there have been other approaches to achieve this, to achieve delivering the virus protein to the immune system. And that is to use RNA, which is one of the messengers found in the human body, which indeed is made from DNA. So in our genetic code, we have codes for making various proteins. So that is encoded as DNA, but that doesn't directly lead to proteins. There's an intermediate messenger called RNA, which is a messenger RNA, which then goes on to code for the production of the viral protein in the cell. So over the last, 10, 15 years, the idea, well, longer than that, actually, the idea of using DNA as a vaccine has been in place. But as I said, over the last 10 years or so, the idea of using RNA to inject the code to get the body to make the protein, this viral protein that you are interested in, within the cells of your own body. So that has also been being developed over the last number of years. But none of these have become licensed as vaccines until, of course, COVID-19 came along. And then there is yet another route for achieving this, essentially getting the cell to make the protein of interest, and that is to encode this gene for the viral protein in an incomplete virus vector. So this is another virus particle, and in the case of COVID, it's an adenovirus that is used, which is a common infection that almost all of us have experienced many times in our lives. But this virus is made unable to replicate, so unable to cause disease. And inserted into this is one of these genes that encodes for this protein. So that's yet another way to achieve, basically, to make your own cells a vaccine factory that will produce the protein of interest. And in the case of, so let's now move on to, sorry. So I should also mention, because these are some of the concerns that people have. So in regard to RNA vaccines, there's a lot of, misinformation going around that this RNA will interfere with your genetic code, which is your DNA, and will cause mutations in your DNA. It will, damage your DNA. It might lead to diseases and cancer and whatnot. Now, this is completely biologically untrue. I mean, in all our cells, every second, we do have RNA being produced, and this RNA is very quickly degraded. So the body has its own mechanism, because once it makes RNA to make a protein, it doesn't want that protein to be made forever and ever. So it's a time-limited activity, and there are enzymes and systems to degrade this RNA after some time. So this RNA that is being injected as part of RNA vaccines, it is no different. It will do its job, get into the cell, allow the cell to make this virus protein, but in a few days, that RNA will get broken down, and there is no way that this RNA can enter, integrate into, or in any way alter your DNA. Right, so let us now talk about COVID vaccines. So one of the strategies to make COVID vaccines is the old-fashioned way, if you like. Basically, grow up large volumes of the virus, infectious virus, of course. So this has to be done in a very secure, safe environment. And then you kill it, inactivate it, and inject it. And so two of the vaccines that are present, that is Sinopharm, which is being used in Sri Lanka now, and Sinovac, which is another Chinese vaccine, are made in that way. And so in addition to this killed virus, there's also a booster to the immune response called an adjuvant. Now, there is no attenuated COVID or coronavirus 2 that is used as a vaccine at the moment. But there are virus proteins that are made in the same way as other viral vaccines. And for example, Novavax vaccine is one of those that has just completed its phase 3 clinical trials, and the results seem very promising, but it's not yet formally registered with FDA or approved by WHO. Then we have these RNA vaccines, and Moderna and the Pfizer-BioNTech vaccines are two vaccines that use this approach. And of course, finally, we have this adenovirus vectored vaccines, and there are a number of them. There's one from China called CanSino. Now that uses an adenovirus type 5. Now, adenoviruses, as I told you, are common infections of humans, and adenovirus 5 is one of those viruses that commonly infect us, and many of us have been infected with it. So the problem of using this adenovirus 5 as a vaccine vector is that many of us will have antibodies to it. And if we try to use that as a vector, you may find that it is not very effective, because our pre-existing antibodies will knock it out even before it has a chance to infect the cell and to make the protein of interest. But it is still being developed. But now the three vaccines that use this successfully, which is AstraZeneca, Sputnik 5, and the J&J vaccine, they have got around this problem in different ways. So the AstraZeneca vaccine uses a chimpanzee adenovirus. So obviously humans have not been infected with the chimpanzee virus, but this chimpanzee virus can infect humans, not infect, I mean, get into the human cells, and can deliver the message to make proteins. Sputnik 5 uses, for its first vaccine dose, adenovirus 26. This is a human adenovirus, but it's a very uncommon human adenovirus. So very few of us have antibodies to it. So that avoids the problem of, this problem with adenovirus 5. But the second booster dose is with adenovirus 5. And then the Johnson & Johnson vaccine is also using adenovirus 26. So these are the strategies that are currently available, and we will discuss some of these. Now, I should emphasize that, of course, as I told you, some of these are old technologies like the inactivated vaccines and the protein-based vaccines, but these RNA vaccines and the adenovirus vectored vaccines are not brand new. As I said, the adenovirus vectored vaccines have been in clinical trials for various purposes, including malaria, including Ebola, for MERS. So they have been in development for some time. And the same is true for the RNA vaccines. They have been in development for some time as well, for influenza and for Zika, for example. But of course, the advent of COVID gave all these old and new vaccine technologies a huge boost to push this forward, to deliver successful vaccines, which luckily they have. Now, another big question is, how is it? I mean, many of you know that in the past, it took a long time to develop and license a vaccine. So there is preclinical work that has to be done. There is then, of course, animal studies that has to be done both for safety and to show that it works in experimental animal models. Then we have to go to what is called phase 1 clinical trials, where the vaccine is given to humans in small doses and increasing doses to look at safety. And then you go on to bigger phase 2 studies, which looks at, again, safety and looks at the immune response, because that is important. That's what gives the protection. And once you go through that, you go to larger thousands of individuals recruited to phase 3 studies, where you actually look at the efficacy of the vaccine against that particular disease. So this process takes many years. Now, so many people think that because, of course, COVID-19, we first knew about it only about 1.5 years ago. So how come we have got to this stage so quickly? I mean, it must mean that people have taken shortcuts. I mean, the fact is that is not the case. So there is a lot that was learned from SARS in 2003. So we knew which protein to target. That's the spike protein of the virus, for example. There had been, animal studies done, and even from the SARS of 2003, even phase 1 human trials had been done with SARS-1. So there was a lot of information that was already there. So it was it was possible to move very quickly into the phase 1 human clinical trials. And of course, under normal circumstances, you would go step by step by step. And of course, these are developed by pharmaceutical companies, so they don't want to put in the funding that is required for a big phase 3 trial, which costs millions and billions of US dollars, unless they're sure, that it has gone through phase 1, phase 2. Now, of course, in the case of COVID, because there was a huge amount of funding made available, they were able to telescope these different phases. So once they started phase 1, very quickly, once they got the earliest results, they started phase 2 and then quickly moved into phase 3. And of course, went through the final regulatory approvals in exactly the same way. So in the end, all the steps that we go through were gone through. And I should point out that there are a number of vaccines that didn't make it. It's not that every vaccine that started this process for COVID-19 has been successful. A number of them have fallen by the wayside. But what we are seeing now are the successful ones that went through this whole process and the very intensive regulatory approvals by FDA or the EMA or the WHO and individual country regulatory authorities. Right, so I've put down here some of the vaccines, particularly ones that are relevant to Sri Lanka and ones that you have heard. So of course, we have the Pfizer-BioNTech vaccine and the Moderna vaccine, which are both RNA vaccines, as I said. We have the AstraZeneca, the Sputnik and vaccines, which are adenovirus vectored vaccines, like I explained. And we have Sinopharm and Sinovac, which are killed inactivated vaccines. Now, all of these require 2 doses for the reason I told you. But there is one vaccine, which I have not put down here, which is the Johnson & Johnson vaccine, where 1 dose gives adequate protection. The Novavax also requires 2 doses. Then another important consideration is the storage for keeping the vaccine stable. Now, these vaccines, the adenovirus vaccines and the inactivated vaccines, are stable at refrigeration temperatures, like most of the other vaccines we use in Sri Lanka in the past for childhood diseases or whatever. But these RNA vaccines do require ultra-cool temperature storage. At -80 or -20 degrees. I've just put down the prices here, but these obviously change depending on many things. Most of these vaccines have been approved by their local country regulator. I mean, all of these vaccines have been approved by the local country where they were made. But WHO approval has been granted to all of these except for Sputnik. And the reason not is the company Gamaleya has not submitted the full dossier in the format that WHO requires to assess it. But Sputnik has been the clinical trial data, including phase 3 data, has been published, and it's quite convincing. Now, of course, what everyone looks at is this number, this so-called vaccine efficacy in the trials. So you have these, what looks like very high efficacy for the RNA vaccines and maybe a bit lower for some of these other vaccines. Of course, vaccines are different and some work better than others. But there are a number of things to keep in mind so that the vaccine efficacy that you see in a trial, for all these vaccines, we can see a pattern. So that is, the efficacy increases with greater disease severity. So in other words, if the vaccine is, say, 50%, sorry, let's say 70% effective in protecting against very mild disease, it may be 90% protective against very severe disease and death, right? So depending on the endpoint that these different trials have used, you may have a change in the efficacy that is reported. Because keep in mind, these trials were not done head-to-head comparing one vaccine with another. Each one has been done separately. And as I said, so different trials have had different severity readouts. Some have been with moderate and severe disease, others have been with mild disease, some even with asymptomatic infection. And also the vaccine efficacy may be affected by what I call the force of infection, meaning how heavy an infectious dose are you exposed to. So for example, clinical trials done in healthcare workers who are working, heavily exposed to COVID patients, the efficacy may be somewhat lower because they are just exposed to a massive dose of infection. So it is not easy to just look at this and say this one is better than that, etc. So I think the important point for the individual, for each of us, is first and foremost, all these vaccines that are put up there have very good safety profiles. And really the best vaccine for an individual is the first vaccine you can get. Because by delaying, hoping for a better vaccine, you may end up getting infected. And then the outcome would be very, very disastrous, because we know that COVID-19 can be quite a serious disease. Now, to explain how these clinical trials are done, I think it is useful to explain this. So this is a process which is called randomized clinical trials. And indeed, they are blinded randomized clinical trials. So what do I mean? You have volunteers that volunteer for this particular study, whether it be a vaccine or a drug, is the same principle. Now, from this pool of volunteers, there is a process by which these individuals are randomly allocated to receive the treatment or the control. Control means you get a mock treatment or a mock vaccine. So you get either the vaccine or a mock vaccine. And indeed, the individuals don't know whether they have got the real vaccine or the mock vaccine. And even the doctors and nurses don't know whether the patients they are injecting are getting the real vaccine or the mock vaccine. And this is important because otherwise whether as individuals or as nurses and doctors, we may be biased by knowing whether the patient got this active vaccine or a control vaccine. So this is what is called a double-blind randomized clinical trial. Randomized meaning this group of individuals is randomly allocated into these two arms, and the double-blind because the individuals don't know whether they are getting the active vaccine or the mock vaccine, and the doctors and nurses also don't know. Obviously, there is a code, and that code is held by the trial regulator, not the company, by the way. It's an independent trial regulator. So now then these people are followed up, and either if it's a drug to see, whether more people get better in the treatment arm compared to the control arm. And with that comparison, you make the necessary calculations of the vaccine efficacy. So here, for example, I've used Sinopharm because that's one of the most used vaccines in Sri Lanka at the moment. And this is a clinical trial. There were 13,700 odd people in the vaccine arm and almost identical number in the control arm. So as I said, they were randomly allocated into these two arms, and then they were followed up. And you can see then of course, they are followed up to see whether they get infected and they develop COVID-19 disease. So you can see that in the first 20 days or so, a small number of people in both arms get infected and get disease. But then after about day 25, you can see that the vaccine group essentially flattens out. Few more cases occurring here, but in the control group, you have more and more cases because obviously this group is exposed to infection and they continue to get infected. And then by comparing the number of cases in the vaccine arm compared to the control arm, you can basically work out vaccine efficacy. And in these trials, obviously, the period of follow-up is relatively short. It's a few months because obviously people wanted the results very quickly. And in this particular trial, the number of severe cases was not big enough to be very confident about protection, but essentially all the severe cases were in the control group. But I think it was only about just a handful. So it's statistically not possible to be sure about that. And also in this particular initial trial, most of the participants were under 60 years of age. So strictly speaking, one could not be sure of the efficacy in the over 60 age group. However, when you look at the antibody responses, which were done in over 60 and under 60, you can see that the antibody responses are quite good in over 60s and under 60s. And of course, there is no reason to believe that the side effects would be different. So when WHO licensed it, they basically pointed this out, that the data is not there for the over 60s, but they basically said that it should be possible to be used in the over 60 group. In other words, can be used in anybody over the age of 18. Right, and of course we will talk about the issue of the virus variants later, but there is data on the effectiveness of this, at least at the antibody level, against, for example, the beta variant, the alpha variant. It works very well. There's a slight reduction against the beta variant, which is the one found in South Africa. And then, of course, as part of the same trial, they look very in detail at side effects, and you can see it's large numbers of people, 13,000 individuals given the vaccine or the control. So you can see the side effects that were found: pain, headache, fatigue, aches and pains, coughing, diarrhea, fever in a very small proportion of people. And of course, you might see this and say, oh my gosh, this is a terrible vaccine. There's a lot of side effects, until you look at the control arm. So now these guys didn't get the active vaccine. They basically got a mock injection. And you can see that these side effects are there in the control group as well. So of course, you get an injection, you will have some pain, etc. And so at the end of the day, the bottom line is that the Sinopharm vaccine is extremely safe. The only vaccine-associated side effects were things like headache and local pain, of course, at the injection site. But by and large, it is quite a safe vaccine, and over 65 million doses have been used so far globally. Now, what about the Sputnik vaccine? A very similar study. I won't go into this in detail, but again, the same type of plot. You can see after the first dose of the vaccine. So you can see in both these cases, already after the first dose, you're beginning to see an effect. But clearly, that effect becomes visible only after about 20 days after the first dose. So again, you can see these two curves separating out. So this is the control group. This is the vaccine group, and this is the control group. And the vaccine efficacy in this particular study, which is published, is about 92%. Then, of course, I'm sure you're heard and you're worried about some of these serious side effects that didn't appear in the initial clinical trials because they were so rare that even with 13,000 or 20,000 or 30,000 people, you may not see it. So you would have heard about this thrombosis in the AstraZeneca vaccine, but you just need to look at the number of side effects, so or the frequency of it, which is in the order of less than 1 in 100,000 of these doses. And these are also particularly in younger individuals, but leading to death only in 1 in a million. Now with RNA vaccines, you don't have this same side effect, but you do have some other side effects like anaphylaxis, which is an allergic side effect. But again, less than 1 in 200,000, and deaths nil, because anaphylaxis, as long as you're in a facility which can has the medicines to treat anaphylaxis, it's a completely treatable condition. Now, of course, you might say, my gosh, 1 in a million, I don't want to risk it. But then, we take risks every day of our lives. This is the number of road traffic deaths in Sri Lanka. Every day, it's about 5 or 6 people dying on the roads. So the risk of any one of us dying on the roads in Sri Lanka is about 1 in 6,000 people. I mean, you compare that with 1 in 1 million. But none of us, as far as I know, say that we will not go from Kandy to Colombo or whatever it is. We will not travel, because you might get hit by a bus or whatever it is. I mean, life, by definition, is a series of risks, and we make a judgment on these risks every day. So it is important to put these risks into context, with other risks that we take every day. Right. Then another question that was asked was about the mix and match of COVID-19 vaccines. Now, theoretically, there is no reason why 2 types of vaccines, one followed by the other, will not work, because you're basically presenting, viral proteins to the immune system. The immune system will see and respond, and you come back and boost it with another mechanism. As long as it's the same proteins that is being presented, you will have a booster response. But the fact, of course, is that the clinical trial data has been done only with the same type of vaccine, right? I mean, obviously, it's not possible for a company to mix their vaccine with somebody else, and it would have been impossible to interpret. So the reason why regulators and departments of health recommend using the same vaccine is because the data, the clinical trial data that I showed you now, is available only for when the same vaccine was given twice, right? However, now there is actual data, for example, for combining the AstraZeneca vaccine followed by the Pfizer-BioNTech vaccine. And essentially, the response is extremely good indeed. Almost better if you have AstraZeneca and follow by Pfizer-BioNTech, your response is, if anything, somewhat better than getting 2 doses of AstraZeneca itself. So in situations like, for example, in Sri Lanka and in other places, it is quite possible to mix one vaccine with another. Indeed, I mean, for example, the German Chancellor Angela Merkel did have, I believe, AstraZeneca first dose followed by Pfizer second dose. And because as I understand, what may be coming to Sri Lanka for the people who have got AstraZeneca may not be Pfizer, maybe Moderna, although we don't have direct data on that. As I explained to you, Moderna is a very similar vaccine to Pfizer, BioNTech. The mechanism is the same, the efficacy is in the same, the clinical trial data, the side effects, everything profile is very much the same. So I wouldn't have any hesitation in saying that for those people who have had AstraZeneca, you can get a second dose of Moderna or Pfizer, whichever comes along. Then another question is, now, of course, how long will my protection from a single dose last? Because there are many people who have had 1 dose of AstraZeneca. So luckily, there is some data from trials from the UK. And you can see that at least for about 3 months, you really have, even with single dose, you have, so this is about 75% protection, which is not too bad at all. But then once you get beyond 100 days, it maybe begins to drop a bit. So certainly the single dose protection will last for some time, but clearly, as for the reasons I explained, it's important to get that second dose to have the increased and the long-lasting protection. I should, of course, point out that there is no data on protection from a single dose of Sinopharm, and there is no reason why anybody should delay getting their second dose of Sinopharm. And I would, strongly recommend people to get their second dose of Sinopharm, and don't assume that after the first dose that you are protected in the same way, because we don't have that type of data for Sinopharm. Then the other question is, if you have delayed the second dose, what is the effect on protection? And again, you can see from these UK studies that you can delay it up to 100 days or whatever, and there is not much. Indeed, I mean, it appears that some delay, rather than the original manufactured interval of 21 or 28 days, a longer duration between the doses seems to give a better vaccine efficacy and also better antibody response. Then yet another question that has been raised is how long does the protection last? So what I'm showing you here is studies that we have done in Hong Kong about natural infection. So how long somebody who is infected, how long does their antibody last? And the bottom line, essentially, we now estimate it will be at least 3 years or probably longer. Of course, there are people, but particularly people who have asymptomatic or very, very mild infection, their antibody titers don't go up so high, and they may fall earlier. So it is recommended that even people who have had infection do get the vaccine, but maybe 3 months or so after they have recovered from the infection. But what about the vaccine immunity? And this is, for example, Moderna. You can see it lasts for over 200. So this is the peak, but then the antibody levels are lasting for over 200 days. In the case of AstraZeneca, here again, you can see there's a slight drop, but essentially quite long lasting. So the consensus now is that both natural infection and vaccines are likely to lead to quite long-term protection. And there is no definite evidence at the moment for the need for booster doses. Now, the only reason why we may have to consider booster doses is not because of the protection falls down, but because the viral variants that are coming may require you to boost your antibody responses so that you have even higher antibody responses. And I'll discuss that in a minute. So now regarding the vaccine strategy in Sri Lanka, at the beginning, when the vaccine was, or before the vaccine was rolled out, the strategy was that we vaccinate healthcare workers first, because obviously they are the people who are facing the bulk of exposure. Then we vaccinate the groups at highest risk of severe disease and deaths. And these are people of older age, people with diabetes, hypertension, etc. And then progressively move down the age groups. And the logic for this is very simple. And indeed, this is exactly what has been used in many other countries. I mean, in Israel, in the UK, in the USA, etc. And that is, if you take the Sri Lankan data, 75% of deaths caused by COVID in Sri Lanka are in those over 60 years of age. And those over 60 years of age are 29 times at risk of dying if they get infected than those under 60 years of age if they get infected. Now, obviously, it's a gradual increase of risk. 60 is an arbitrary point, but you have to choose something. And the second thing is the population in that over 60-year age group is 2.7 million. So it is perfectly doable. Indeed, even with the vaccine doses that are currently landed in Sri Lanka, we could have vaccinated a big proportion of that healthcare workers, of course, which is done, and this group who are at highest risk. And then gone on to vaccinate those with comorbidities, diabetes, and hypertension. And if that had been done systematically, we would be in a much better place to face, whether it be the alpha variant or the delta variant or whatever, when it comes, because those who are most vulnerable are protected. And that means the hospital system is protected, the ICUs are protected, and the deaths are prevented. Unfortunately, so as I said, the primary aim of this is to prevent death and severe disease and to avoid hospital capacity being exceeded. Because once that happens, even patients who can be saved will not be saved. But unfortunately, the policy changed, and you know better than me. I mean, on the one hand, there was the attempt to try to vaccinate small areas of the country where there's an outbreak, with the idea of trying to stop an outbreak. Now, this is doesn't make any sense, because as you know, to find a case, in a particular Grama Sevaka area, it will take some time. The testing, there's delays of 5 or 6 days. So by the time there is a case, already the infection probably has been spreading quite a bit. Now, the incubation period for the infection is 5 days. So that means if somebody is exposed to an infected person, within 5 days, that person will be infectious and having disease. So, by the time you go around, get activated and start vaccinating, already the transmission and infection has taken place. And I showed you the data that Sinopharm and Sputnik or whatever, it takes at least 20 days after giving the first dose for you to be protected. So there is no logic to this. Then, of course, there was also the idea of vaccinating the young workforce to stop transmission in the community. Now, of course, if you had then the population to be vaccinated is 11 million. I mean, if you had 11 million doses and could roll it out very rapidly to vaccinate everyone over 30, fine. But we didn't. So given the fact that we didn't, what effect has the current rollout had on the ICU admissions and deaths? Sadly, not as effective as if the original strategy had been followed. So really, I mean, thankfully now, basically Sri Lanka has gone back to that original strategy, going down the high-risk groups and coming down systematically. Right. I think we don't have too much time, so I will now quickly try to address the question of viral variants. Right. So being a virus, it replicates inside living cells. It requires living cells to replicate. It cannot replicate in water and soil and all this stuff. Now, when the virus, particularly being an RNA virus, I won't go into the details of that, when it replicates inside a cell, these RNA viruses do make errors when they copy one strand to another. When the virus replicates, it has to make a copy of itself, and it's a copy, its genetic information, which is in RNA. And when RNA is copied from RNA, there is a much higher rate of mutations than when DNA is copied to DNA. So the mutation rate is higher. Now, most of these mutations that occur in this replication process are bad for the virus and they don't survive. So we don't even see them. And some of them don't really kill the virus, but they have no biological effect. It doesn't make it better or worse or more infectious or less infectious. So we see them and we can use them to track how the virus is spreading, but there are no real significance other than for the purpose of tracking the virus. But a very, very small number of them can, more or less by random chance, give the virus a survival advantage. Most often to increase transmission, or maybe to escape the immunity in the population that is building up through natural infection or vaccination. So this is what has happened right from the very beginning. At the beginning of Wuhan, the virus continued to undergo these mutations. And right through this time, indeed, but of course, back in February last year, already there was one particular mutation here, which is called this 614G mutation. And that increased the transmissibility of the virus. And within a few months, basically all the viruses worldwide already had this mutation. So it's a mutation on this spike protein, which allows the virus to infect the cells more efficiently. Then, of course, the virus continued to diversify, but as I said, many of these diversification didn't have any effect. But then we did have, for example, this particular change, which is the UK variant, now called the Alpha variant. And that clearly had survival improvement, a faster transmission. And similarly, this is the South African variant, which is now called the Beta variant. That also has increased survival and also some ability to escape prior immunity. So it is only a few of these variants that become important. Now, what is the effect of these variants in Sri Lanka? You have the first wave in Sri Lanka going back last year to April period, some cases. But then you have the famous Minuangoda cluster, and that was associated with the emergence of this particular variant into Sri Lanka. This happened, the mutation happened back in February last year, but luckily it didn't get to Sri Lanka until August, September. But the fact that that is more transmissible led to that big cluster there. Then, of course, as you know, in April, the Alpha variant, the one first detected in the UK, got introduced into Sri Lanka, very rapidly took over and has become the dominant virus. And you can see the scale of the outbreak was much, much bigger because the Alpha variant is at least 50 times, I mean, not 50 times, 50% more transmissible than this previous variant. So you can see the effect of that increased transmissibility. Now, of course, we hear about the Delta variant, and it has been detected in a number of places. And we know from studies in the UK, for example, which has been badly hit with Delta variant, that the Delta variant is 50% more transmissible than the Alpha variant. So if this gets going in Sri Lanka, we are really going to have a much bigger hit, unfortunately. So we need to be prepared for that. Now, this is just to remind you of these different variants. We have the Alpha variant is the one initially detected in the United Kingdom. The Beta is the one in South Africa, and Delta is the one initially detected in India. And the reason for giving them these names is because WHO and countries don't want to be named as, you know, with the name of a variant. So now we don't incriminate any particular country. So the concerns about these variants is increased transmission. All of these do have increased transmission. Some of these, particularly these two, have the capacity to escape vaccine immunity a bit. In terms of disease severity, not very dramatic, but maybe a slight difference. For example, some suspicion that the Delta variant may have some slightly altered, increased chance of getting hospitalized, for example. But the main effect is on transmission for all of these, and that is what we need to be worried about. Now, what about the effect of vaccines on the Delta variant? Because I'm afraid we have to be prepared to face this in Sri Lanka as well. Now, luckily, the Pfizer-BioNTech and the Oxford-AstraZeneca, because these studies come from the United Kingdom, so these are the vaccines that are used there. You can see that if you compare it with the Alpha variant, there's a slight drop in efficacy, but it's still quite good. So the reduction is about 5 to 6%. But essentially there is good protection and probably even better protection against severe disease and death. Now, of course, as we discussed, you know, there is so much of false YouTube clips and so many things that are going around, you know, which unfortunately, they are very nicely produced. But, you know, anybody can put on a nice bow tie like this guy and say he is Dr. ABCD and give a very impressive speech. And you wouldn't know whether this guy knows anything, whether he is knowledgeable in this field or not, or, you know, or whether what he's talking is complete rubbish. And I must say, I've seen a lot of the YouTube videos that are being circulated around, and I've seen these people who say that they're experts. And in the case of most of them, I have never heard of them. And I can tell you that I would have heard of anybody who was an expert in the area of COVID or in the area of vaccines. So there's a lot of this conspiracy theories and misinformation, not just in the case of vaccines, but in many things. But I'm afraid, but we can discuss this further on as well. Now, I just will end by pointing out that when we talk about transmission and outbreaks, we are talking about the vaccine, which is here. That is one part, or immunity due to past infection or vaccination is one aspect of tackling this outbreak. The virus itself is another aspect. And of course, we have the virus is changing and becoming more and more challenging. But then those are not the only two things. We do have the human behavior, which is our contact patterns and public health and social distancing measures that we use, including masking, social distancing, things like that, and maybe the environment to some extent. So we really have to keep in mind that it's not just a matter of vaccines. We do have to also maintain these other protective measures to reduce risk. So I think just to summarize, I hope I have tried to explain that the COVID-19 vaccines that are now in use are safe and effective. The safety and quality have not been compromised because of the speed, the fantastic speed with which they have been developed and licensed. And as I pointed out, not all of those vaccine candidates that started have come and become licensed. A number of them have failed along the way. That's because the system is doing its job. As I said, the best vaccine for an individual is not to look at 94% versus 72%, but the first vaccine that is available to the individual is what you should get, because all these by and large safe, and having some protection as quickly as possible is more important than trying to get 2% or 3% more protection. The side effects from vaccines are much lower than other risks we routinely take, and do not believe these conspiracy theories and YouTube videos. Vaccines are most effective at preventing severe death and disease. Severe disease and death. So even if sometimes you have people who have had vaccines who may get infected, who become PCR positive, that may happen, but by and large, they do protect people from severe disease and death. The duration of protection seems to be quite promising, but as I said, the question of boosters is likely to be more driven by the variants and whether vaccine updates might be developed, which already they are being developed. The mixing and matching of vaccines is theoretically sound, and as I showed you, the data is available for the AstraZeneca, Pfizer or AstraZeneca RNA vaccine combination. So Moderna, as I said, should be equally good. And I've just put out some websites for further information. And with that, I thank you for your attention, and we'll be happy to take the questions and answers. Thank you.
Thank you very much, sir. That was a wonderfully detailed presentation. And I think you've gone through many of the questions that were asked. Since you're talking about truths and myths today, I think I'll just briefly summarize. The major areas that questions were asked on were about vaccine efficacy, and you touched on the point prevalence, the point estimates of efficacy of each of the vaccines, and that they're not directly comparable, but that obviously the first vaccine available is the best. You talked about duration of protection. You've talked about mixing of vaccines, and that it's possible, and that's certainly a direction that we might go in because of we need the AstraZeneca, at least a second dose for those who got the first dose of AstraZeneca. You talked a little bit about side effects and of course the variants, and those were the major areas that people had asked questions on. Now, a little bit about the myths. One of the major myths and one of the major reasons why especially young females are not getting the vaccine is they think it's infertility, that it causes infertility. Would you comment on that, sir?
Yeah, so there is no, first and foremost, there is no logical reason why any vaccine would cause infertility. And indeed, these vaccines, as part of the safety, animal studies that are done, they undergo a series of tests looking at the effect of these vaccines in experimental animals on fertility of the animals, and also the development of the babies. The newborn in pregnant mothers in animal studies. So all these vaccines have gone through that process of testing. There has been no safety signal, and there is no indication at all. Logically, I think, Champa, you are probably better off than me to comment on this because you're an immunologist. And there is no logic to any fear that these vaccines will cause infertility any more than any of the other vaccines that we readily take. Tetanus, diphtheria, influenza or measles or whatever it is. So, but if please add any further comments you may have on that, because I realize it's a major concern. Yeah.
I think so. With this particular vaccine, from what I've read, the story started with a scientist, I think from Germany, or someone from Germany, claiming that the spike protein was very similar in structure to one of the proteins that is found in the reproductive tract, and therefore if we start forming antibodies against that protein, we might start forming antibodies against either the reproductive structures or the fetus. And this, it was a hypothesis that was put forward, and this then went into general circulation as something that was true, and then I think that's what got out of control. But it is
but like I said, in certainly in experimental animal models, there is no evidence at all that any of these vaccines have any effect like that.
Then there are people who think that the spike protein itself, whether it's if you form it in the body, is harmful to the body.
Well, I mean, the spike protein is just another protein. I mean, the body has tens of thousands, probably hundreds of thousands of proteins that we make every day. And then when we get infected with the common cold or with influenza or with whatever, other viral proteins infect us. So the spike protein is just one protein, and there is no logical reason to believe that this particular protein is going to cause any major harmful effects compared to many of the other proteins that we eat. Our body also makes all of these proteins, or we get exposed through being exposed to bacteria and viruses. So there is no real reason why the spike protein is likely to be any different. And again, in the safety signals in animals, or for that matter now, at the moment, there are tens of millions of doses of vaccine of different types that have been administered. And except for those very rare side effects that we talked about, there is no evidence of either short-term or longer-term adverse effects.
Then there is also a belief that the body becomes, after vaccination, the body becomes unresponsive to other medications or future vaccinations.
So again, there is no logic to that as well. I mean, after vaccination, the body will make antibodies and T cell responses, basically immune responses, to that injected protein. Just like when we get infected with the common cold or whatever it is, we will make an immune response to that. Or we get influenza, we'll make an immune response to that. So that there is, again, no biological rationale that is going to make us less responsive to another vaccine or another medicine. I mean, of course, at the moment, it is recommended that you don't mix 2 or 3 different vaccines at the same time. Say, for example, you give the COVID vaccine and you give a flu vaccine or a pneumococcal vaccine. I mean, in theory, that possibly can be done in the future, but clinical trials are being done to see if we can give 2 vaccines, because I'm talking about in the future, when we may have to give booster doses or whatever it is in due course, whether we can give it together with some other vaccine that is being given. At the moment, the recommendation is not to do that type of mixing, because obviously you don't want to distract the immune system from focusing on what you want it to do by giving it something else to also deal with. So simultaneous administration of multiple vaccines at the moment probably should be avoided, but there is no logical reason, as you know better than anybody else, Champa, that the immune system will be unable to respond to something else just because you responded to the spike protein of the virus. I mean, right through our lives, we are meeting different proteins and we are responding to them, making antibodies and T cells.
Yeah, exactly. So vaccine hesitancy is a real thing. I mean, for all these reasons, probably. Have you encountered this in Hong Kong? What are your thoughts on vaccine hesitancy globally, locally?
Yes, unfortunately, vaccine hesitancy has been a big problem everywhere, and in part because of all these, YouTube clips that are going around, giving complete misinformation, because it's very difficult to, and also Twitter and all these ways of social media that is spreading misinformation. But I must say, in Hong Kong, we have another challenge, and that is the fact that we have controlled COVID to such an extent that actually there's very little cases in Hong Kong. So people are thinking, oh, well, why should we go and take the vaccine? Because the risk of you getting COVID is pretty low. But of course, that's not the situation in Sri Lanka, for sure. And even for Hong Kong, I mean, this is a huge mistake, because there's no question sooner or later, just like in Australia, you can see, there was introduction of the Delta variant. In Singapore, they have had problems. So I mean, the only way that societies can get back to anything resembling pre-2020 is for the population to be immunized and for us to be protected as a group. I didn't have time to discuss about herd immunity, but we can discuss that if we wish. But until the vast majority of us in any particular geographic place has either been naturally infected, which will be disastrous, or being vaccinated, the threat of COVID is going to be with us, and we'll be in perpetual lockdowns and back, and lockdowns and back. So, I mean, I really, don't see any option other than for large-scale vaccination. And the countries that have succeeded, such as the UK, such as Israel, and now increasingly the USA, you can see that they are more or less getting back to normal. But we won't really be able to do that for any prolonged period of time unless we are vaccinated.
Right, sir. So the next three questions are sort of put together. There was a question of whether this virus is worse than other viruses. COVID-19 virus is worse than other viruses in terms of mutations and virulence and variants. And can we, I mean, given that it mutates and variants are forming, can we actually get rid of it 100%? Can vaccination keep up? And, can we get to herd immunity? Can we actually get to herd immunity?
Yeah, so those are good questions. Now, as I mentioned, this coronavirus is an RNA virus, and I explained that RNA viruses have a much higher mutation rate than other DNA viruses. So, for example, RNA viruses includes HIV, includes influenza, includes hepatitis C, for example. And one of the reasons why we have not been able to develop a vaccine for HIV is because that virus mutates so quickly as well. And influenza, as you know, also undergoes mutation. That's why we need yearly updates of the influenza vaccine. I know that's not widely used in Sri Lanka, but people may know about it. Now, SARS coronavirus 2, I don't think is in that same league. It does undergo mutation being an RNA virus, but when we look at these different variants, so whether we take the alpha variant from the UK and the beta variant in South Africa, they arose completely separately, but they appear to have popped up common mutations, which would suggest that the virus has a limited number of options to increase transmissibility or to escape antibody protection in the population. So that is comforting news. I'm afraid, to say comforting, but it does suggest that the virus doesn't have unlimited capacity to change everywhere, and that when once we cover some of these variants, we should be able to essentially protect the human population from severe disease. Now, the last part of your question, whether we can get rid of it 100%, I don't think we can get rid of it 100%. I think what we are trying to do is to convert a very nasty disease, which capacity to cause serious disease and death and put our hospital systems under severe strain, to a more common cold or flu-like illness, which we can live with. And I think that is the expectation, and that is the aim. I don't think you will, or we can get rid of the virus completely. Over.
Right, sir. Thank you. So it's basically something, our new normal, something that we'll have to get used to.
Right.
So,
yeah.
Sir, there were a few questions about the local standards of maintaining, say, cold chain in vaccination, about procurement of vaccines, and, could things have been done better? Where is Sri Lanka in, vaccination, getting vaccines and distributing them, and so on and so forth? Do you have anything to add to that or comment on that?
Well, I would actually put that question back to you, but before that, let me comment. I mean, I think we know that Sri Lanka has a very good track record of vaccine delivery in general. I mean, it's the overall vaccine coverage is very high. Many of the common childhood diseases have been well controlled, etc. So, but I will leave you to talk in detail about the cold chain and all those things. Now, in regard to the question of the vaccine procurement and things like that, again, I think you probably know better the local scenario. But I think I can say one thing. I mean, in most countries, you have this same strategy, where we go through expert committees to look at what are the possible vaccine candidates out there, which are the ones that are reasonable, and look at the data in detail. And from each vaccine company, you get a huge dossier full of information. So that is gone through. And in the case of Sri Lanka, the NMRA will go through that. In the case of Hong Kong, we have an organization that goes through that. And then these vaccines are licensed and then put into use. But I think I will pass that back to you, Champa, to talk about the local situation, both in terms of cold chain and in terms of the regulatory systems.
Thank you, sir. So really what I think is that the maintenance of cold chain and the maintenance of standards throughout the vaccine delivery system is actually very good. It's very robust, because although for most adults, this is the first time that you're getting a vaccine, the vaccine delivery for children has been happening for years, and it is happening all the time. And all the vaccines that we have up to now are within that 2 to 8 degree framework. It is only once we get the Moderna that we will be getting a vaccine that is outside the current established cold chain. And all the requirements for maintaining that are actually, everything's online. You can see that everybody, the temperature requirements, the documentation required, the returns that are required from all the individuals down the cold chain, the checking that has to be done at each step, what's checked, the dosages, values, residual volumes, everything is documented. And we saw this happening when we were vaccinated as healthcare workers. So I mean, from personal experience and from what I've seen of the very, very robust public health sector that we have, I would say that the vaccine distribution system in Sri Lanka is on par with anyone in the world. And you don't need to worry about the standard of the vaccine that you are getting. And this relates also to the vaccine procurement methods. So that is also available online. And some people had asked questions about this. So as Sir was saying, it is very similar. So the companies will approach the NMRA and say, these are the vaccines that we have. The NMRA will appoint an independent expert committee who will go through the documentation. They will see if the vaccine has been approved in that country, if another stringent quality assurance organization has approved it, if the WHO has approved it, the independent people go through it and see if the safety data is available and so on. So it is a process, but it has been expedited as much as possible. And remember, I mean, the first vaccines were rolled out in December, or in the rest of the world. As healthcare workers, we were vaccinated at the end of January. So it happened reasonably fast. At the moment, it is easy to look back and say, well, we could have got things faster. But I think at that time, there was, a lot of, for the other vaccines, even in January, February, the stage 3 trial data hadn't come out. WHO approval was not there. So I think in terms of vaccination and procurement, the SPC, Dr. Prasanna Gunasena, who's chairing it, they have actually done a marvelous job on that. So I think they're doing the best they can. That's actually what I'd say. So moving on, there have been quite a few questions on this about vaccination in pregnancy and lactation, sir. A few comments.
Yeah, so first and foremost, lactation is quite easy. I mean, of course, in the very early stages, the vaccines, when they were rolled out, they had cautions about pregnancy and lactation and all this stuff. But again, there's no theoretical reason why a vaccine of any sort would have any adverse consequences, for the baby with breast milk. And indeed, what we know now is that, as with other vaccines, that it is an advantage to the baby, because the mother being immunized, the antibody then crosses over to the baby in the breast milk. So there is no, indeed, it's an advantage to be immunized if you're breastfeeding. Now, in regard to pregnancy, again, as I said, animal studies have been done in all these vaccines, as I explained before. And then, of course, there are now, thousands of women who have been vaccinated with many of these vaccines. As you know, mothers, women who are pregnant are at much greater risk if they do get COVID or developing severe complications and death. So you really have to, you really have to balance that with whatever other concerns that you may have. So all the data from pregnant women who have been vaccinated does say that there is no safety signal at all in terms of adverse outcomes for pregnancy. But I think, of course, if it's in the first trimester of pregnancy, I think, it's important to discuss with your obstetrician and come to an assessment of whether you can wait a bit before you get vaccinated or not, etc. It all depends on the level of exposure that you may have and how you may balance those risks. So I think that would be an individualized assessment that has to be taken. Over.
Right, sir. And that is actually the current guideline of the College of Obstetricians here as well. That in pregnancy, in the first trimester, it's better to avoid, but you can discuss with your obstetrician, but in the second and third trimesters to go ahead. What about allergies, sir?
Well, you're the expert on allergies, Champa, so I will put that to you.
Right. So in allergies, there is no the only contraindications for vaccines in allergies is if you have had previous allergy to a severe allergy to any of the vaccine components. And how do you find that out? Well, if you've had an allergy to a vaccine before, then that is something you should tell your healthcare worker about. If you had an allergic reaction to the previous vaccine dose, then that is something that you need to also tell your healthcare worker about. In Sri Lanka, in addition, those are the international guidelines, but in Sri Lanka, in addition to that, we also take allergy to other things, including drugs and foods, severe allergy, like anaphylaxis. That's where you can't breathe and you're all swollen up and your blood pressure drops and you need oxygen and adrenaline. So anaphylaxis level allergies. As a contraindication or a reason not to get the vaccine. Some of them have nervous system disorders like Guillain-Barré or uncontrolled epilepsy also as contraindications. But in general, just because you're an asthmatic or you have allergies to, normal, mild to moderate allergies to foods or pollen or anything, those are not reasons to not get a vaccine. I know that at the beginning of the vaccine rollout, certain places where vaccine were given, people with allergies were not given the vaccine, saying that it's not allowed. I think that miscommunication has been corrected now, and everyone, you have to inform because you will be observed more stringently. But even if you do have allergies, you can get the vaccine. So then there's been a couple of questions on Regen-COVID about the new drug. I think it was recently approved by the NMRA. What are your comments on that, sir?
Yeah, so I think we've been talking about vaccines and indeed, keeping in mind that, this virus, we only knew about it 1.5 years ago. We have made fantastic progress on the vaccine front. I mean, honestly, much faster than I thought would be possible. But on the treatment front, in terms of treating the infected patient, in terms of specific antiviral treatment, we haven't come as far, as I had hoped. Now, there are, of course, it's very important. There is basic management of the patient with oxygen and, ventilation and things like that as the symptomatic care, which is being done very well in Sri Lanka by and large. But then other than that, in terms of specific treatments, there are at the moment only 2 proven treatments. One is the use of dexamethasone in severely ill patients, and then more recently tocilizumab, which is also a molecule, it's a treatment that modifies the hyperinflammatory response of the patient, because part of the damage to the lung is because of this hyperinflammatory response. But still, we don't really have something that targets the virus. Now, and there were various things that have been tried, but not proven to be so successful, such as remdesivir. And then also, it was thought that using convalescent plasma, that is, you take blood from a person who has recovered from COVID after a few months, so they will have good levels of antibody. And then if you use that to infuse that plasma into a patient, the hope was that that will help the patient to recover. Unfortunately, those trials have not proven very successful. But then the other track that was taken is to make these what are called monoclonal antibodies. So when we make antibodies, we have individual, of course, Champa, you know this perfectly well, but let me try to explain it. There are individual cells, B cells, which differentiate into plasma cells that make antibodies. And in an individual, there is a whole range of different plasma cells that are churning out these antibodies. And each one is slightly different to the other. So what has been done is to try to identify specific clones, specific lines of these cells, making antibodies that are very effective in killing the virus, and then mass producing this by genetic engineering methods. So in other words, choosing a very effective clone of antibody, that's why it's monoclonal compared to polyclonal, is what, as a human, we have a range of clones making this, but one clone selected with very high efficacy, cloned and mass produced into a therapeutic. Now, Regeneron is a combination of two of these monoclonals. Each one is targeting the spike protein, the same place we are targeting with the vaccines, but now we are targeting it with antibodies. And the main aim is not to try to vaccinate people, but to treat people who have disease. And there are a number of these combinations out there, but this Regeneron has now gone through this, a fantastic large clinical trial in the UK, which is called the recovery trial, which really has yielded so much of important information, including the effectiveness of dexamethasone, the effectiveness of tocilizumab, and now the effectiveness of this Regeneron combination. And what they have shown is that in patients who are hospitalized, so when patients are hospitalized, you can test their blood for antibody. There are some people who are already making antibody. There are other people who have not. Now, the people who have already making antibody basically do better. So presumably they are making this antibody response like I discussed at the beginning, and they are essentially, trying to fight the virus on their own. Now, the people who are still negative, those are the people who benefit from this Regeneron treatment. And what they showed is by targeting that group of people who are sick enough to be hospitalized and who don't have antibody at the time of hospitalization, treating that group with Regeneron improves survival. So that's at least one additional step. Unfortunately, it's a very expensive therapy, but it's one additional treatment that we have. Now, in theory, of course, you can also use it to prevent disease if you give it, if you're exposed to infection and very serious exposure. And in theory, by giving these types of antibodies, you may prevent the disease developing as well. But that is not the use that has been licensed at the moment. It is really to treat patients who are severe enough to get into hospital. And those who have not made antibody yet. Over.
Right, thank you, sir. So there are a ton of questions. One set which I will put together is how long, this is something that you mentioned, but obviously a concern. How long will the effective vaccine last? Would a booster be needed, say, at 6 months, 1 year? And can the vaccine, will the vaccine push the virus into becoming a more virulent pathological virus?
Right. So these are, I suppose, two questions. So firstly, how long it will last? As I said, the data at the moment is looking very good in terms of both the immunity from natural infection and from vaccination. Now, the problem, of course, is that with these variants coming along, I didn't have time to go into that in detail, but as I indicated, the vaccine is made with the early virus. I mean, the original Wuhan-like virus. And the virus has undergone all these changes which we discussed. So the vaccine elicited antibody is very effective at killing that original virus. And it is equally effective, for example, at killing the alpha virus, the one that's circulating in Sri Lanka right now. But with the Delta virus, it is a bit less, not a lot less, as I showed you the clinical trial data also, a bit less effective. But then you go to something like the South African Beta virus, there's about a 10-fold or 8-fold loss in titer. You mean you need to have a higher level of antibody to achieve the same protection. So because of that, when you are confronted with these types of variants that are partially escaping the killing effect of the antibody, you may need to boost your antibody even higher, maybe even with the original vaccine. So we may have to consider that at some point. But then also already the number of these vaccine manufacturers, including the RNA vaccines like Pfizer and Moderna, they are already making vaccines targeting these escaping viruses. And luckily, it seems that if you target the South African variant, the Beta variant, that is very effective against the Beta variant. It's also effective against the Alpha variant, the old variants, and all these things. So at some point, there may be a need to maybe give a booster either with an existing vaccine, basically just to boost your antibody response further up, because as I explained, it's not a complete loss of protection. It's just that you may be losing a bit of protection. So if you boost it further higher, you will achieve that old protection or even better. Or maybe in the future, we may have these more variant specific vaccines. So sometime down the road, we may have to think about that. But at the moment, I think the first issue is to get, the population of Sri Lanka vaccinated. And as I said, starting from those who are at highest risk and then coming down to the lower risk groups. Over. And then sorry, there was another part to the question. I think I forgot now.
Yes, sir. Will doing that push, say, development of another variant?
Yes. So that kind of works both ways, right? So if you have no protection, if you have no vaccination, and you allow the virus to run rampant, which of course is what it has been doing all this time, the chance of variants arising are increased, because the more the virus replicates, the more people it infects, the more chance it has of undergoing variation, adapting to higher transmission, and all these things. So if you can bring down the transmission by social distancing measures and vaccination and a combination of these, you're reducing the chance of these variants emerging. That's certainly the hope. Now, of course, it is also true that when you are vaccinating more and more of the population and the virus has to find somewhere to go, it will presumably try to find some ways to escape the immunity in the population. So and indeed the South African variant or the Beta variant, we believe that is how it arose, because the area in South Africa where it arose last year was very heavily infected. More than 50% of the population already had been infected. So presumably the virus had to change somehow to survive. So we may expect to see some of that happening. And that will happen whether it's natural infection or vaccination. So, that doesn't make a difference whether you're protected one way or the other. But as I said, it seems that a number of these virus variants, such as the Beta variant or the Gamma variant in Brazil, both of them trying to escape the immunity, essentially are doing it by the same mutation. So like I said, maybe the virus doesn't have too many options to escape. So if we can cover those, ultimately, we may be able to get control. But again, to emphasize the fact that although these variants are a problem, basically the vaccines do protect. You may lose a bit of protection, but at least you will have, reasonable protection from severe disease and death. So we come back to the issue of, trying to roll out vaccination as fast as possible.
Right, sir. There's a question, does antibody level following vaccination reflect the degree of protection from disease?
Right, so that's, now again, this is, I'm sure Champa can give a 1-hour talk on this, but to be brief, there are a number of mechanisms of protection when we talk about protection. So of course we have antibody, then we have the T cells. Now with the antibody, there is the neutralizing antibody, which is called, the killing antibody, but there are also other mechanisms by which antibody can protect. So at the moment, we don't know exactly what is contributing to protection in what proportion. But one thing we know is that neutralizing antibody is a good marker of protection. Now, then the next question is, what is the level of neutralizing antibody that is required for protection? What is the threshold? Now, again, we don't have good data on that, but it is beginning to come along. So I think we are now having some idea what type of neutralizing antibody levels are needed to confer protection. But again, there are other mechanisms that do protection as well, you see. So I think it's a very complicated topic, and we are still beginning to get to grips with that particular issue.
Right, sir. There are a couple of questions on the gap between first and second jab. So there's a question like, what is the ideal jab? Sorry, what is the ideal gap? Can this be delayed 45 weeks? More than 100 days? There are a lot of people who are 4 months, they've had the first dose of AstraZeneca. They haven't had the second dose. It's 4 months past. How worried should they be?
Yeah, so the initial interval was, designed to be 3 weeks or 4 weeks. And that was, with many things in mind. I mean, trying to get the people protected as fast as possible as well. But now it is clear with a couple of vaccines, I mean, that is with AstraZeneca and also with BioNTech, that that extending that gap a bit, to maybe 8 weeks, 9 weeks, you have maybe even better antibody responses. I mean, slightly. I mean, it's not a huge difference, but it seems better. But then you really have to, you have to balance that, right? So if you delay too long, people may forget to come for their second dose. You may get infected. You may get exposed in the meantime in the gap and all this stuff. But of course, now in Sri Lanka, because of the AstraZeneca problem, people have had to delay it for now quite a long time. Now, I think I saw a question in the chat, and they were asking really whether if you delay it more than, I forget what it meant, 6 months or something, whether that means you completely have to start the vaccination process again. I don't think that is the case. It's not that it suddenly disappears. The first boost will give you some primary memory which can be boosted. Now, obviously, you don't want to extend it to 2 years or 3 years or whatever it is, unnecessarily long for all these reasons. But just because of this particular situation, that because you may have had to wait 6 months or whatever it is, doesn't necessarily mean that when you get your, whether it be the Moderna or whatever you get, that you'll make no response. You will make a good response. So I think you can be reassured with that. Yeah.
Right, sir. And will it be problematic? But basically what you're saying is that both doses are needed, because there's a question on whether you can get one vaccine and get away with it. Any of them, say Sputnik 1 dose and get away with it.
Well, one vaccine is better, one dose is better than no dose for sure. But I mean, that is definitely not, that is not the desirable outcome. I mean, there's no reason why, unless of course you, for some reason you just don't have any vaccine at all. But I think, if just theoretically, let's say the people who got the AstraZeneca first dose, let's say they don't have Moderna, they don't have anything, they don't have another AstraZeneca, they don't have Pfizer, they don't have Moderna, I would then say, get Sputnik or get Sinopharm, and indeed Sputnik theoretically, because it's the same platform, theoretically should work very well also. So I think you should ultimately get the second dose. And I hope, all of those individuals will be able to get one thing or another. If it's Moderna or Pfizer, that will be fantastic. But failing that, I think any of these vaccines, the other vaccines would be good rather than nothing. Over.
Right, sir. What about those who've been infected, sir? Vaccination for them?
Yeah, so for people who are infected, it is indeed recommended, that they do get a dose of vaccine. Of course, they are less priority because they have some protection for sure. But for the reasons I suggested, because particularly the people who have asymptomatic infection, their antibody levels may be quite low and may disappear quite quickly. And there are occasional examples of people getting reinfected, although such reinfections are generally mild. But ideally, the recommendation is to get a vaccine dose. Now, from, again, at least 3 months after you have completely recovered from infection. And the data seems to suggest that one dose is all you need. So the studies that have been done where they gave people who have been infected, they gave one dose, and they had a very good antibody response, which of course makes sense, right? I mean, it's like the first dose they have already had in terms of their infection. So clearly you get the second dose, you have a very good response. And indeed, then when they gave a second dose to these people who have been infected, there was no improvement in antibody. So, many people would suggest that wait 3 months at least, and then get one dose if it is available, obviously, for that particular category of people. And only one dose should be adequate. But then again, you have to go by the local guidelines, and then you may have other issues, such as if you want to travel, whether one dose will qualify you as a vaccinated person or not. So I think all these issues have to be considered in that decision in the end. Over.
Right, sir. So there's one question on allergies. So there was some specific allergies mentioned, brufen and self allergies. And yes, so I'll just quickly answer that. Yes, you can get the vaccine even if you have those allergies. Then there's a question on physiological and medical conditions where COVID-19 vaccines are contraindicated. Any comments, sir? Did you want to add anything on that?
No, I mean, I don't think there are physiological and medical conditions that preclude, I mean, except for, we talked about the question of anaphylaxis, and then it's not an absolute contraindication, but clearly it requires, medical assessment and risk assessment. And then if you're giving it under, close medical supervision, etc. Then there's also the question of people who have clotting problems. So maybe again, I think Champa, I think you have given some thought to that question. Maybe you can address that.
Yeah. So there are, I mean, for specific vaccines, they have, say, for the Sputnik, they do talk about epilepsy and Guillain-Barré syndrome in the past. Not really any other medical conditions, like so common medical conditions. I know there was a big rumor going around that diabetics can't get the vaccine, and that's completely untrue. All diabetics should get the vaccine. So heart disease, diabetes, renal disease, liver disease, all the common diseases, you can get the vaccine. There is a question on any known effects on psychotic or autistic patients. No, not that we know of. And the psychiatric patients have all getting the vaccine if they are eligible. So we're a bit short on time. So, sir, there's two questions. One is, what happened at the Seychelles? Should we go from Sinopharm to Sinovac? And also, somewhat related to that, how did we get through the Spanish flu? Did it go away? Will we get through this the same way?
Yeah, so in the Seychelles, basically, the Seychelles has been using Sinopharm to a large extent. And as I think what the person who asked the question is implying, they are having an outbreak of infection. But my understanding is that although there are cases in vaccinated individuals, and these are presumably people who have had both doses of Sinopharm, there are very few, hardly any severe disease and death. So they are being protected from the severe outcomes. So keep in mind that if you look at that, that efficacy chart that I showed, and of course I said you don't just look at it exactly, 73% versus 80%, but the Sinopharm, the protection rate, the efficacy rate was about 75% or whatever it is. So that means maybe about 1 in 4 people who have had Sinopharm may get infected. But the important point is that you are still protected from severe outcomes, severe disease and death. And from what I understand in Seychelles, that is the case. So basically the vaccine essentially is still doing that job. And I don't think changing to Sinovac, is a solution, because at least from what you see in terms of vaccine efficacy, although, like I said, you can't compare these numbers, Sinovac is no better, certainly on the basis of the published data compared to Sinopharm. So, over.
Right.
Sorry, you're asking about the Spanish flu and how that disappeared. Yeah. So in case of the Spanish flu, of course, at that time, there was no vaccines or anything like that. This is 1918, right? Indeed, they didn't even know what was causing it. They didn't even know it was a virus, indeed. So essentially, the management was social distancing, right? I mean, lockdown, social distancing, wearing masks, everything that we are doing right now, before the vaccines came, was what they were doing. And of course, ultimately, the infection killed about 2% of the population worldwide. And people got immunized ultimately through getting infected, which is a very painful process. It killed about 50 million people globally. So we certainly don't want to go through that again. So I think, thankfully now we do have vaccines, and we should use them. Over.
Right, sir. So very quickly, there was a question on, do we have the infrastructure for the -70 required to deal out the Moderna and Pfizer? And yes, the infrastructure has been built up over the last few months. I'm not sure whether it will be island-wide infrastructure, or maybe it might be restricted to a few provinces at the beginning. But the vaccines also do not need to be at -70 right up to delivery. They are stable at slightly less cold temperatures, so that will certainly help. Then moving on. Would you talk a little bit about the Sputnik Lights? This is a question that we're getting, the single dose vaccines.
Yeah. So indeed, I did have that in my chart, but I didn't have time to. So as when we discussed the adenovirus vectored vaccine, so Johnson & Johnson is a single dose vaccine, right? So with that single dose, it gets about 70% protection or something. Now, AstraZeneca also with a single dose gets about 67-70%. So with the single dose. So, and Sputnik Light, I did have it on that chart. The first dose, so Sputnik Light is basically the first dose of the Sputnik 5, the adenovirus 26. And although it's not published, but the claimed data is about 70%. So it's not very dissimilar to Johnson & Johnson and one dose of AstraZeneca. So I think it's something that can be considered, but I think we would want to see more data on the long-term duration of that immunity. It's not just the short-term antibody and the short-term protection. Whether you will maintain long-term protection with a single dose, I think is something that indeed even for Johnson & Johnson is something that we need to look at. So it's something that again, one dose is better than nothing, but whether we need a second dose or not, I think is something that needs to be looked at. And again, I think there was one of these questions there about local research. And I think this is exactly where, local research is important. For example, to answer these types of questions, for example, whether, you could have We could have tested whether those people who got AstraZeneca, you get a single dose of Sputnik, will that work? I mean, that could have been done in Sri Lanka. I mean, you wouldn't do it anywhere else because nobody else has this particular problem. And certainly we have the capacity to do it, and maybe, we should have done it. And then this question about the duration of protection. I mean, I know, Champa, you're planning to do these types of studies, and I know Professor Nilika Malivage is doing some studies like that. So we really need a research effort, and that should be adequately funded and supported, very importantly, because there are many questions that we can only answer in Sri Lanka for particular questions that Sri Lanka faces. And this is exactly where research is needed. Over.
Right, sir. There are a few questions on vaccination in children and the move in Sri Lanka to reopen schools.
Right. So, yeah. So as you know, some of these vaccines like Pfizer and even Sinovac now has been tested out in children and found to be safe and effective. But then the question is, unless we have enough vaccines to vaccinate all the 50-year-old, 40-year-old, 30-year-old and everything, how do we prioritize? And I think it is certainly important to vaccinate the teachers for a start in reopening schools, because as you know, I mean, children can get infected, but indeed, actually, the data seems to suggest that particularly young children, primary school, under 10 age children, they seem slightly less susceptible to even getting infected. And there are various theories about that in terms of receptors in the nose and all this stuff. But definitely, I mean, children, even if they do get infected, by and large, they have good outcomes. Now, I know there are occasionally very few children who develop this multi-system inflammatory disease, and that is very distressing. But by and large, they do have good outcomes. So if you're looking at in terms of priority, I mean, I think we have to think carefully, what would be the priority, because I mean, if you can vaccinate children and the adult population, young adult population, the old adult population, everybody, simultaneously, fine. But if not, we have to go in some priority order that will get us the most benefit for what we are doing in the immediate, short and medium term. Over.
Right, sir. What can you say about prevention of transmission by vaccination, sir?
Yeah, so now the vaccine clinical trials were not done with the aim of looking at transmission. I mean, if you just think about it, it'll be quite difficult to do that, right? I mean, how on earth would you measure that? So there is some data. There's some data on asymptomatic infection. That's from the AstraZeneca trials. And the AstraZeneca vaccine does seem to suppress asymptomatic infection as well. So if it suppresses asymptomatic infection, by logical extension, it would be reducing transmission. Now, but probably not to the same extent as it reduces disease, right? Now, on top of that, of course, we also see that in these countries where the vaccination has been, higher and higher proportion of the population, such as Israel, basically, they have been seeing a reduction in transmission, even in the non-vaccinated, not yet vaccinated population. So it is suggesting that this, at least the herd immunity effect there is a reality to that. Now, at what point that kicks in, I think it's a progressive effect. And, it's estimated that it will take at least 75% of the population to be vaccinated to achieve that. So these vaccines do have an effect on transmission, but like I said, that is not what the clinical trials were measuring, and we don't know exactly how much that effect is taking place. Over.
Right, sir. So there is a question about vaccinating immunocompromised patients. I think anything you want to say, sir, about that? I can tell you about what's going on in Sri Lanka, but globally.
Yeah, so I mean, basically, there is no harm in vaccinating immunocompromised individuals. it probably will give them some protection, and it also depends exactly what their type of immunocompromisation is. But it is depending again on the extent of immunocompromisation, their response and protection may not be equivalent to someone who is completely immunocompetent. But maybe you can expand. And I know that there are clinical studies going on in a number of places, including in Hong Kong, where we are recruiting immunocompromised patients for these studies. And I think I know that you're doing some studies in dialysis patients and things like that. So maybe you can talk about that, Champa.
So currently there is no, the trials are going on, and there's as the data is coming out, I think global guidelines are being made. Javadrapura is looking, Professor Nilika's team is looking at some populations, and at Peradeniya, myself and my team are also looking at some populations. So far, the colleges are making guidelines on their based on the world literature and based on what guidelines are available. So for there is no harm in so far. Based on what's available so far, there is, as Sir said, there is no harm in, say, somebody who's had an organ transplant, or someone who has malignancy or blood, like say leukemia, lymphoma, one of the blood malignancies, someone who's on immunosuppressants because they have autoimmunity, or some other problem from taking these vaccines. But as Sir said, we get antibodies. So what we're doing is trying to see with how many people develop antibodies and how long those antibodies last. Will these people need a booster shot, say maybe a booster shot sooner? Will they need an additional booster shot, say within 6 months? So those are some of the areas where research is ongoing, and a lot further, as Sir said, a lot of research is needed, and a lot of organized research and directed research is needed. So for now, there is no contraindication, or there is no reason to not get the vaccine. Whatever immunity you can get is a good reason to get it. How good it will be, how long it will last, we don't know. Right, so we are almost at the end, almost out of time. Just one last question. I can see Professor Pradeepa appearing and disappearing. So just one last question. There was a question on efficacy and what efficacy actually means. So does 75% efficacy mean that a person vaccinated has a 75% higher protection compared to a non-vaccinated person, or that 3 out of 4 people are protected?
Yeah, so I think it is the latter. So it's 3 out of 4 people are protected. So if you vaccinate 100 people and a vaccine efficacy of 75% means that 75% of the time you will be protected, but still 25% of the time you will get infection. But from the data that we have, it suggests that even those who do get infected are protected from severe disease and death, which is much higher than 75%. So those exact numbers of severe disease and death data is not fully there, because you can imagine that even if you do a clinical trial of 40,000 people, the chance of seeing individuals in that trial who develop severe disease and death is going to be very small. So that's why we don't have accurate estimates of that. But on the basis of field, real life field studies, the evidence does suggest that the vaccines are more protective against severe disease and death than even the published estimates of efficacy, which is protection from infection. Over.
Right. So last question, I promise, last question. Antibodies, are they being done? Is it worth doing? Any thoughts?
So antibody tests are being used for certain purposes, and indeed, in Sri Lanka as well as elsewhere, for discharge of patients, after they recover and things like that. But I don't think people should be going around getting antibody tests because if, say, for example, if you're saying you're vaccinated and you want to go and test your antibody, because like I said, it's not just antibody that is protecting you. You also have the T cell arm that is protecting you. And then secondly, if you are doing antibody tests to look at this type of protection from a vaccine, you really have to have a very specific type of antibody test, which is targeting the spike protein, because some of these antibody tests are looking at the other proteins of the virus, which are not there, except for the Sinopharm vaccine. In these other vaccines, it's only the spike protein that is there. So if you go and test your blood against some of these other antibody assays, you will get negative and you may get confused. So, and finally, as I said, we don't really know how to interpret an antibody result, because we don't know what is the threshold that you can call protected versus not protected. So I think for all these reasons, I don't think it is sensible to just go around doing antibody testing left and right, except for research studies and for very specific purposes, like for discharge of patients. Over. But again, you may have thoughts on that, Champa. So maybe I give you the last word, the very last word. So.
No, I have nothing really to add to that, sir. I mean, we use it here as discharge criteria for asymptomatic patients and for immune suppressed patients. When the PCR can be a little, distracting and can't be used as a discharge diagnostic criteria. Other than that, it's not widely available. And as you said, I mean, there are multiple kits available, and sometimes it's very difficult to decide what kit to use and what it means and how to interpret that. And at the moment, none of us are experts in this field. So I think we'll leave it where it is for now. But certainly a lot of people are very interested in getting the antibodies done, because it gives you a sense of security, thinking, oh, I have antibodies and I can walk around without a mask now.
I think maybe the very last word then should be that, even when we are vaccinated, we should still maintain our masks and caution, because, it is not a free pass. So I think we really need to maintain our other precautionary measures for a long time to come. So.
Yeah. Right. Thank you very much, sir. I think it's been a wonderfully informative session. I'm sorry we tired you out so much. I think we've answered as many of the questions as possible. There were a few questions that on extreme virology that we didn't get to, but I think we got through most of the truths and myths that we could. So, Prof. Pradeep, over to you.
Thank you very much. It has been a long session for you too. And first and foremost, I take this opportunity to thank Professor Malik Peiris, our key speaker today. I know we all know that you have a very busy schedule, but thank you very much for taking time off to educate us. And our moderator and the discussion, Dr. Champa Ratnatunga, thank you very much. I know both of you have spent so much of time, because we have received so many questions during our initial survey at the registration stage. One person, I noticed that one person had like 12 questions. So you tried. I know it has been like long few days for you too. Thank you very much once again. And again, it's like when I see you two on the screen, I feel like, we are merging two generations of Pera alumni together to educate another group of alumni, as well as, the general public who joined with us today as well. Thank you very much, sir, and Dr. Champa. It's a wonderful experience for all of us as well. And again, last not the least, all of our participants, we had quite a large number of participants. So questions itself shows the interest of the topic. And thank you very much once again, and thank you very much those who joined as well. There will be an exit survey. Please, fill that up, and we will continue on our AAUP Global Forum, and we'll bring more topics and more interest topics for you all as well. Thank you very much once again, and stay safe. I thank all my team, behind the scene, all the EXCO members who helped me, help all of us to bring this. It's a team effort, even though I just appear on the screen. So there's 35 odd people in the team. I thank them as well. Thank you very much once again, and everyone stay safe. Thank you.